What I'm doing is coming behind the sternocleidomastoids, and I'm finding the anterior transverse processes of the spine, and then I move medial. And as I move medial, what I'm looking for is to, essentially on my fingernails, the tips, I'm trying to get behind the thyroid cartilage, and as we move it anterior, I can't hear you.
She's talking to her.
Okay.
Got it.
And you heard her?
I think.
There we go, like that, and out. And I'm gonna come in again, and you can see the reaction. Again, this isn't proving anything, but as I do this, either anybody who's good with observation, what are you noticing? Anything?
The arytenoids is kind of evened out.
Yeah, yeah. Now, Pat, if you go ahead and repeat what Michelle had asked you to do before.
The low to high.
Sure.
E.
Now, as someone is doing that, whether it's swallowing or voicing or moving their head, I'm paying attention to what I feel throughout that movement, all right? And I felt a little something over here. Go ahead and do it again.
E.
Like right there. Pat, what do you feel?
It's tight.
It's tight, okay? Is it relatable? Is it familiar?
Yes.
When do you feel this?
All the time.
All the time, okay. I'm also in the area of the cervical nerve roots. That's why I learned this technique, and I'll talk about that a little later today. But what if we moved and I did an anterior drag?
That feels good.
That feels good. Now everything's reversed, so it's a little hard to see that. But as we take hold, and whether I prefer to do it this way, where I come in the heels of my hand, grabbing hold of the thyroid cartilage and doing an anterior drag. Or what we're going to be doing this morning is a superior lift, or a drop, or even traditional laryngeal manipulation. Again, none of this proves that, so there's up at the hyoid. None of this proves anything therapeutically, right? But as we do this, and I think especially this one here, and you can see the internal response of the structure, of the tissues, etc. And I just believe it's making that sensory connection and awareness that potentially drives a motor change. If I move in with one side, can you get a little over the epiglottis? Or no? There we go. There we go. Perfect. Okay. And then we do the other side. You can see the skewing right there. Everything's on my right, or on her right now. And then we move over to the other side, and what you see is not as much skewing on that side. Those are the type of things that I'm looking to see if possibly there's a diagnostic correlation between what I'm doing and what you're seeing through the scope. So I'm going to do it on the right side again, and we get some nice, a little bit of skewing there, but not so much there. I'm going to show you a clip in a few minutes of someone when we did this who had dramatic skewing, all right? Michelle, is it you that said you know Shelby? Yeah, okay, got it. And get over the hood again, if you will. There we go. So, obviously, when I'm working with a patient, we're looking for things that have meaning to them. Now, Pat, I'm going to make an assumption here that some of that isn't necessarily your voice or your swallowing or things like that. It might be more neck pain?
Yes.
Yeah. As I push backward in this space, I can feel that little gnarly area, for lack of a better word. Sometimes when I find those, I'll just move medial behind the thyroid cartilage. Now, as I do that, Pat, what do you feel?
It actually feels good. It's like something that needs to be worked on.
Okay. She's not there yet. What do you feel?
It just feels good.
Feels good. Does it feel like it's relating to any of the issues with your voice?
No, it feels like this darn car wreck that the lady hit me head on. That's what it's related to. That's what it feels like.
Got it. So where do I need to go to get to some of the things that you were talking about when you had the microphone? Where do I need to go?
I don't know. Maybe down here.
Maybe down here. So I can easily move down behind cricothyroid, if you will. All right.